Oh my goodness, how are you?
The face. Yes, no.
Yeah, Doris. How are you?
The face very well.
Good morning. How are you?
So
good to see you.
Brought us to the rate of 33.8%.
Go ahead, because
we had a special guest lecturer in our midst. This lecture will be trying to prepare one, you know now, but we've not been able to achieve it. But today we are realizing our set objective. The objective we set since last year. And our sister, a great woman, a Soluta, she trained in School of Nursing here in UBTH. She practiced nursing here with us in UBTH. We worked in children emergency. She was in children emergency room for years before she traveled out. So she has an experience both within Nigeria here and outside Nigeria. We have been trying in our own little way, but we can improve on what we have been doing. That's why our sister is here this afternoon to tell us her experiences here before she traveled and her experiences there, so that we can improve on our nursing practice. So please be attentive so that we can learn together. Nobody's too old to learn. Are we too old to learn?
No.
Anybody that is tired of learning is tired of life. And we are not tired of life. So we keep learning and we keep improving ourselves. Both our practice, our education, and all. So to talk to us this afternoon is one of us, our sister, Mrs. MABEL Okunbawa ni Omorogeva. You are welcome.
Thank you so much.
Great UBTH nurses. I'm so grateful that I am given this opportunity to address UBTH nurses. I trained here in UBTH from 1986 to 1989. So I was 27th intake with Madam Provost. So it's just, I'm greatly honored to be on this side to address my colleagues. I'm sure some of my classmates may be in the midst there. There you go. Thank you so much. This is so wonderful. I don't know. I like to be a nurse. If I want to come back again and again and again, I don't think I want to do any other profession. Yes. You see, you are wearing white, and that white signifies purity. You are looking like angels, you know, and that is nursing. You know, your uniform, you know, says everything about you. Purity in the body, purity in the spirit, purity everywhere. I love nursing. I don't know how to start, but we've already been in the morning section talking to the students. So we're going to have to cut off the knowledge part of nursing. We've all been trained very well by people. I don't know. I don't know where to start because I don't want to step on toes, but it's okay. Like I asked, I gave a history to, you know, in the morning session. I don't know why you are a nurse. I don't know if any of you have found or you've defined that thing that gave you the foundation for nursing. Some of us went into nursing because some boys will come from abroad just to pick you and take you abroad because you can make money. Is that what we are telling the little ones graduating from high school, that they can easily be a nurse and make money? Why are you a nurse? Do you have your foundational story behind your nursing profession? Because I do. Because that question is very, very important in how you care for other people. I was 12 years old when I found my story. I was sick. My mother took me to the hospital. And I had a very unique experience in that admission. You know, 12 years old, a young teenager. As a teenager, that is when we are being formed. I received a care, the kind of care that left an indelible mark in my soul. As a teenager, I promised myself that I will not give this kind of care to anyone. Because of that bad experience as a young teenager, I told my mother I was going to become a nurse. And that story has been my story. Because every level of nursing that I, went through, they will always ask for you to write a statement of why you wanted to be a nurse. And that has been my story. And that is the motto that drives my care. Because nursing is caring. So, because I didn't want to be treated the way they treated me, I have been looking to that experience. When Madam Provost approached me 3 days ago, she said, nursing practice is going down. I said, what do you mean it's going down? She said, the attitude behind our nursing practices in UBTH is down. I said, really? She said she wanted me to put a spin of how we practice over there to make sure that our practice here is standardized. I said, I don't know what you're asking for. I said, because it's not like that. Whatever I'm coming here to present is just information. It's just like a spade in the ocean. It's not going to really make any difference. Because, Madam Provost, you cannot do this by yourself. Okay? It's almost like a pyramid. If we want to take it departmentally in the nursing department, you have your CNO on top of that pyramid. You have your student at the base of the pyramid. Okay? You want to take it at the level of UBTH level, you have your CMD on top over there, and with the other branches to the other department. I said, what you are asking is so big that you are not going to be able to just do this with one lecture. As a matter of fact, for it to become transformative, it's lifetime. It's lifetime. Yes, we want to become like how they do it at the international level or worldwide, but Africa as a whole, there is something endemic in our lives or in our practices. The question of who know man. Who know man? Because the CMD would like to interfere with my nursing care as the head nurse of the unit by making a single phone call from his bedroom. Because I am trying to discipline a young nurse on my unit who is not doing the right thing. That's how we practice in Africa. Unfortunately, if over there, even if my father is the CMD of that hospital, and I misbehave or I don't carry out my nursing care on my unit properly, my father will never pick up the phone to talk to the head nurse. He can't because there's another boss ahead of him. See? So everybody will have bosses ahead of us. Unfortunately, in Africa, everyone who has a little power thinks that the boss stopped right there. And it does, yeah, it's true. So with that, we're going to need the grace, a lot of grace of God to help to implement the kind of changes that we want to implement. Mrs. Agawa, you are welcome, ma'am. Welcome, sir. We're here to talk about ethics in nursing. When I think about that word ethics, the only person that I remember is Mrs. Agawa.
Thank you. God bless you.
I don't know how many of you that Mrs. Agawa taught. She taught me. Look at that. Mrs. Agawa taught me nursing, clinical nursing. Where is my bedtime? Where's my bedtime? Thank you. Thank you so much. Mrs. Agawa taught me how to carry a bedpan with pride. Okay? The way she taught how to carry this bedpan. Remember the content of the bedpan? It's heart. When you carry that bedpan, she said, with pride, with dignity. Okay? With smiles on your face. I see the content of this bedpan is dessert. That is how she wants me to carry the bedpan. And I'm so grateful because, you see, the way she taught how to carry the bedpan, she knows that you are going to come in contact with the content of the bedpan every day of your practice. Let's say you don't even if on your day off, you use the bathroom, don't you? You remember Mrs. Agawa. What about your facial grimaces when you clean that patient who is sitting in a poop? She's saying that you should smile doing it. Let us stretch this a little bit. A patient who look at your face. You know, when we all want to use the bathroom, we need privacy. Actually, we don't even want anyone to be around. That is why they design air freshener. You don't even want anyone to smell your poop. But think, as a nurse, putting on this white, you're carrying this bedpan, you're cleaning this patient is looking at you. If he or she has a way, she doesn't want you to do it for her or him. But you're doing it smiling, giving her emotional support through the process. That patient will look at you as an angel. Is that the kind of nursing we are practicing these days? Now, Ms. Agawa, you were not in the morning lecture. I just wanted to quickly finish with the bedpan story. I had an experience last week here. My mother was in the hospital for hip surgery. Okay. And I had spent the night. I wanted to go home quickly to freshen up and come back and stay with my mom. I had about 5 nurses sitting around the table. What did they say? Madam, where did they go? I said, I want to quickly go home. My brother want to quickly take me home to freshen up so that I can come back and take care of my mother. Oh, no, you're not going to go. I thought, why? She said, somebody have to say, if you are going, let your brother say. I said, but I cannot drive around here. But my brother have to go with me. And we live very close to the hospital. It was like I was committing a crime. From the nurses, I was begging that I would be back very quickly. So I left. She said, come back, Rico. I said, okay. Unfortunately, you know how good our roads are, right? So we ended up spending about 2 hours. When I came back, oh my goodness, like I committed crime. She was like, oh, you are late. I said, I'm so sorry. And where you left your mother, immediately you turned around, your mother needed a bedpan. Oh, that was a crime? But I did not challenge her. I wanted to enjoy the experience all the way. So I said, oh, I'm so sorry. Well, then she needed a tissue paper. I said, it was in the... Before I finished the statement that the tissue paper was inside the bedside table, she was like, exactly, I don't know where that one is. You're supposed to not to have left. You're supposed to have given your mother a bedpan. I said, okay, I'm so sorry. I didn't need to do that. I won't do it again next time. She said, okay. And I thought to myself, was she talking about the bedpan that Mrs. Agawa taught me? Where did we go wrong? When has giving a bedpan to a patient becomes a family responsibility? I thought it was part of our nursing job. That was so traumatic for me. But I didn't want to disclose my identity yet. So, Mrs. Agawa, you told me to carry that bedpan with pride. But the kind of nurses nursing practice we're having now, it is our family responsibility. The bedtime. Another thing I want to say about Mr. Agawa is the conscience that is gone now. It looks like we don't have consciences when we render nursing care to our patient. And that is why our nursing care is becoming so poor that those in power want us to not talk to us about it. Conscience. When Mr. Agawa taught me how to do wound dressing, Mr. Agawa has a way of leaving you with a police officer inside of your soul. That's what she did with me. I don't know about you. Wound dressing. As long as you wear gloves every day in your practice. Mr. Agawa so did it that putting on gloves becomes the police officer that is inside of you. How many times do you have to wash your hand to open this sterile pack? She so beat it that when you see a sterile pack, you'll be scared. So, when I'm donning my gloves for any procedure these days, or since she taught me how to open a sterile pack to do that wound dressing, I remember Miss Agawa. She said, when you pull out curtains and you are left in there with your patient, it's between you and your God. She said, when you open the pack, you know how many times you're supposed to wash your hands. And you end up donning your gloves. And it's time to touch the sterile field. And in your conscience, you know that that thing is contaminated one way or the other. Assuming you are taking care of an invalid patient, a patient that is mentally incapacitated, it's between you and your God as you open that sterile pack. Nobody's watching you, and you still carry on to finish that wound dressing. Let's say the patient is diabetic. She came to you with diabetic ulcer. Let's say it was just here. And because you were not conscientious, and you still went ahead and do that dressing. Remember the sin of omission and commission? Now, you have introduced MRSA, methicillin-resistant Staph aureus, into that wound. And that bug requires a high dose of antibiotics. And that wound refused to heal. Remember, she's diabetic. And now we're going to stretch it forward. And now the toes are getting necrotic. And now the wound has broken down. And now the patient is going for BKA or AKA. Because you decided not to stop this whole process. Because you wanted to cut corners. Because this patient is not your father, it's not your mother, it's not your brother, it's not your sister. Because Mr. Agawa is not there to re-echo it to you that you just contaminated. And you go ahead and you do that dressing. And now this person is is somebody's loved one. And she's going to be walking with a limp for the rest of their lives. How do you live with that? In the meantime, if you want to bring your brother to this hospital, you are looking for maybe Madam Provost, because she is your right-hand woman. You call her first, Madam Provost, I beg, my sister, they come there today. She want to do they want to do surgery for, I beg, the nurses. Which doctor do you think I should? This is what we do. We want the best care for our own loved ones. What about that person that got AKA or BKA because of your negligence? Is that not somebody's loved one? That is the kind of nursing that we are doing now. That is why I had to say my story of my 12 years old story. I don't know what your story is. We want to effect changes. It starts with you, I. Nursing ethics. I want to introduce myself a little bit more. I'm married and I'm a mother of 4 children. The reason why that is important in this lecture is because when I think about nursing, I see it as marriage. Everything that makes a marriage to be successful makes you a good nurse. If you want your husband to love you, you have to be loving. If you want the kind of care from, high-grade care from your husband, you have to be caring. I see marriage as an institution of sacrifice. It's an institution whereby you don't expect a thank you. If you are a nurse and you are expecting somebody to say thank you after the care you gave, then you're wasting your time. Because nobody can thank me enough to carry that hot bed pan. Nothing is sufficient. So which means nursing care is sacrificial. I don't want any thank you from anyone other than go home, lay on my bed, and just be peaceful that I made somebody happy today. That is my thank you. Plus, do no harm. I'm a nurse anesthesiologist, so going further a little bit like that has renewed my conscience in taking care of a patient. Because over there, I don't need a doctor to tell me what to do to give anesthesia because of the kind of training. Which means when a patient sees me in the pre-operative area, the first thing that comes out of their mouth is, oh, thank you, please, I don't want to die. I'm like, oh, no, you are getting it all wrong. I'm just an instrument to be used, okay? I'll do my part. I want you to do your part. I love to serve. So I talk to them in that magnitude. I don't need anyone to think I'm God. But the kind of nursing we practice in Africa, people are being seen as gods, mini gods. When I watch nurses render care to their patient, you are just God. Like, if these patients don't do what you tell them to do, they can, pass you to the next level. It cannot be like that. Remember, today I'm the giver. Today you are the recipient of my service. Tomorrow, you will be the recipient too. As God has created all of us, we are humans. I might be healthy today, but I might be the patient tomorrow. Think, if you are a patient, what kind of care do you want to receive? Nursing philosophy. Nursing is committed to and accountable for safe interprofessional practice as evidenced by consistent utilization of the nursing process, collaboration with our colleagues, and achievement of quality outcomes. We are advocates for people by promoting the delivery of the right care and at the right time. Things are bolded here. Committed. How committed are you to your patient? Do you see it as just a business? Or just one of those on the bed, sick bed? Or are you seeing your patient as a sickler? Your nursing care requires commitment. What is commitment? The same way you are committed to your marriages. If you want your marriage to succeed, you have to be committed. You have to play your part. That's why when I see people complaining about their marriages, I'm like, oh, no, it's not like that. You have to be in a marriage as if there's no other person in existence in that marriage. It's all you. Whatever my partner does in that marriage is a bonus. If you walk like that in a marriage, there's no reason why it will not be successful. The same thing with nursing care. It's the same thing. You are committed. Whatever it takes for my patient to heal, I'm going to be an advocate. If the doctors, remember, you are the eyes and the ears and the nose and everything of this patient. The doctors, they come as strangers. You know your patient inside out. So therefore, if your doctor comes in there, he's trying to recommend things because you know your patient. You are the one to straighten them up. Okay? That this patient is actually allergic to penicillin. And you are just ordering, let's say, cefazolin. And so you are a patient advocate. The doctors will listen to you because you are communicating important information at that level. You see? So you are their eyes and their ears. You have to stand up for your patient all the way. How consistent are you in utilizing your nursing process? Ms. Sagawa taught us that The other professors, they taught us that. Because I don't know how you carry out your nursing care. If you make that nursing process to be the central point of your healthcare delivery, you see that you never go wrong. There's something called the right kind of care and the wrong kind of care. Unfortunately now, we are all, bending towards the wrong kind of care. That's why our patients, that 1 week I spent in the hospital with my mom, she's, the way she was telling me, that's how we do it here. No, it shouldn't be. Like I told them in the morning session, just think, without the patient being sick in the hospital, do you all have a job? So, patient is the most important thing in the hospital setting. Trust me. From the CMD to the student nurses, if we don't have sick patient in that hospital, it's a business. In case you don't forget, this is a business. Okay? I don't think the federal government allocates money and says treat all these patients for free as they come in and go out. It's a business. So if you don't do this business very well, we're going to be out of business. So now the only thing we are selling, which is the patient care, is of no quality. So what are we doing? So let us wake up. That is what our founder's vision is. Excellence in human caring. I thought when they say something is excellent, that is without flaws. So can any of you really come out here and say, oh yes, the care delivery we give in UBTH is excellent? No, because I have first-hand experiences, not experience, experiences with UBTH, University of Benin Teaching Hospital. Supposed to be one of the best hospitals in Edo State. The kind of experiences I had here, my institution of training, everything contradicted what Mr. Agawa taught me. And I was not the only student in that class. Why is that? What happened? What changed? What changed? It is my imagination because I cannot begin to reason it. Excellent in human caring. Right now, I like to take away that word, human. That human thing there, just take it out and put animal caring. No, for real. That is how porous our nursing care is now. We don't have attitude surrounding our care. We are not conscientious at all. Our patients are being complicated with their cases. It looks like we are taking care of robots. So, definition of ethics. That word is derived. It's derived from a Greek word, ethos, which means a way of living. I was telling them this morning that what is a way of living? I kind of look at that as like a culture, the way you live your life. In my home, if I turn off the light, for example, I should be able to make my way to the kitchen, get the knife, because I am methodical in my home. Everything is arranged the way I want it to be. It's so organized. I don't have to be looking before I know where things are. Because that's my way of living. So my children knows that they should not put that pair of shoes on the countertop because I'm a healthcare provider. I nag them with that. Okay? They know that when they hit that door into the house, they need to go straight to the bathroom and wash their hands. They know how many seconds they're supposed to wash those hands. They shouldn't touch anything in the house because I don't want them introducing anything into that house. That is my way of living. What is your way of living in nursing? What is your way of living in nursing? It should be consistent. Okay? Truth be told, the way you live your personal life, that is the way you live in nursing profession. If you are conscientious in taking care of your family, same thing. It shows out there. So, that is what is ethics. You will so practice nursing that you don't care about what other people are doing. Because it's your way of living. You have your conscience. That's your internal police officer that is guiding what you do in the nursing practice. The onset of nursing ethics can be traced back to the 19th century. At that time, it was thought that ethics involved virtues such as physician loyalty, high moral character, and obedience. I highlighted the physician loyalty. Okay? I don't have anything about the doctors. I love my physicians. But over the years of practicing nursing over there, I discovered one thing. As a matter of fact, a surgeon behavior in my unit over there in ICU is what pushed me to go further my education. He was so autocratic in his way of, operating. He was a vascular surgeon, so he was bringing in the most amount of money to the hospital. So he was respected, And with my personality, I didn't like it. I wanted to go further. So I went out there and I did what I had to do to become a nurse anesthesiologist. And I left that hospital. That physician loyalty that spanned off from the beginning, 19th century. When I was in UBTH, in children emergency room practicing, that physician loyalty thing, I don't know how much we are practicing it now. It's the only thing that lingered on. So what happened to the high moral character and the obedience? What happened to those? We buried those and we just put the physician loyalty. Listen, nursing and medicine are supposed to be practiced on a mutual basis. If you know what you know, if you know your worth, the physician will not allow you to be all that and lay down. Okay? If you educate yourself and go further and begin to speak the language they speak, okay? You are not telling, give 1 cc of whatever. That's how I, coach the students that go through me in my preceptorship program. If he is talking you need to be talking with him at the receptor's level. Okay? When they see you operate like that, they can trust you more to do most of the things they do. That is where the discrepancies are. We go to school to advance and we get the credentials behind our name. MABEL, Kumbawa, RON, VVF, UCF, ECT, all of that is all over the badge. But we went through school, we were not transformed. Why would he respect you? It's not, because you don't know anything. That is why we keep that physician loyalty lingering on all along. So think about that. When you advance yourself in this nursing profession, when you come back, let them see the transformation in you. Not just seeing the transformation in you, challenge them. I want to make a difference in this. Pick up something from the clinical setting and say, listen, Dr. Obaseki, I don't like the way this thing is operating. I want to make a change. He's going to tell you, what do you mean? Present your case. You see, the doctors like to be challenged like that. As long as, at the end of the day, everything you deliver is about patient safety and growth for the institution. These are the 7 nursing ethics that you must adhere to, that is missing now, that makes our Madam Provost to tell me that our nursing care is falling out of place. Justice, beneficence, non-maleficence, accountability, fidelity, autonomy, and veracity. Listen, if any of you, if you are practicing nursing right now, because you have your internal police officer that will tell you if any of this is lacking in your practice. What is justice? The right to be treated fairly and equally. Okay? Are you treating your patient fairly? To my mother. Let's reason this together as nurses. First and foremost, this alcohol pad. Remember, for it to be efficient, you need 70% alcohol here. I don't know how you do it in your unit. Some of them have this bottle of alcohol. They open and close, open and close, open and close. The bottle is not dated. There's supposed to be a date and time of opening that bottle for us to know that the content is still, you see? But no, she's coming with this cotton on this hand and on the other hand. And she say, Madame Tom. Because my mother saw the needle on this hand, so she knew she was going to get an injection. Here she is. She also almost broke my hand for holding it so tightly on that hand. And she's like, I was just watching this nurse perform her procedure. She wiped and she gave and she left. I quickly whispered to my mother, ask her, is that pain medication? I needed to ask her so that when I medicate my mother, I know what I'm doing. Is that pain medication? Hey, nurse, I bet na pain medicine you give me. This is her saying, yeah. You could barely hear. She walked away from the patient and she said, yeah. Come on, guys. Before you touch that patient, remember, without this patient, you are not going to eat or feed your family. Okay? Mama, good morning. You slept last night? How are you doing? There's something we call identifiers. That medication actually should not make it out of the medication room without the sachets in them. Okay? The syringe that contains the drug needs to be labeled with the patient's name, the date, and the time. Because some drugs do have expiration date and time. For example, Propofol, which I used to put my patient to sleep, if that thing is drawn after 6 hours, it begins to decompose. You have to trash it and take another one. Okay? So, she brought an empty syringe, assuming, as she was coming with the syringe, and somebody interrupted her on the way, all with this cell phone that we all carry everywhere. It rings, and she decided to pick it. And then after that conversation, this is true, it happens. And now, you think you have my mother's medication, now you go to Peter James and begin to give it. What if that patient is allergic to what you have now? What if you have medicated another patient? But if that syringe is labeled with the name and the date and the time, you know the owner. You will never be distracted, right? Mama, how your pain? In a scale of 0 to 10, 10 being the highest of your pain level, and 0, no pain. Where will you put your pain? Mama will give you the number. Maybe it's 6, my picking. Okay. Then you know how to medicate your patient. Mama, this pain medicine, when I want to give you for injection, it will help with your pain. It will pain you small. Make you not look at, okay? I will first wipe. You are explaining the procedure all the way. All the way. Okay, Mama, are you ready now? After you wipe it, Mama, take a deep breath. Here we come. See, Mama is mentally ready to receive that medication. Your emotional support will calm Mama down before she receives that medication. We're not dealing with robots. We have to be conscientious with what we do. And if that is what you do in the pediatric unit, listen, you are damaging these children's feelings, like somebody did to me at age 12. Thank God, it was just unique to me to turn mine into positive. Some people will turn it into negative way of living as they grow up. You know. So fidelity. Every time I hear the word fidelity, I think about marriage. I think about marriage. That tells you that nursing is an institution of marriage. So it means that if we practice all of these, you are accountable. Now nurses are no more accountable for their actions. They're not. Because they don't have the conscience, actually, to tell them that they did the wrong thing. You're not accountable. I overheard them discussing things at the nursing station. All I could think about was, they are not even accountable. Autonomy. Expressed as the right of competent adults to make informed decisions. Your patient is part of your nursing process. Your patient, whatever decision you make, they are central. Okay? They cannot be excluded. You know why? I know my body. I, MABEL, know what I take in the secret. I, MABEL, could be doing some drugs like cocaine, heroin, marijuana. You don't know that. Okay? It is when you come down to my level to understand that I am central in your care. Then I'll be able to tell you what I do in my closet. I'll be able to trust you with that information that I do drugs. Some patients have HIV. They don't tell you. They hide it. Because you have not given them the scenario to trust you. They'll hide it. And here you are, so careless now. You think you wanted to maltreat me? I have HIV, I'm not going to tell you about it. If you handle me the way you handle other patients, God forbid, because some of them will come and give the injection actually with their bare hands. And now the blood that comes out of me, you are infected. Because you didn't develop that trust with me as a patient. That is what they call odumadubody. Veracity, truth-telling. How truthful are you to your patients? With their care, with what you are giving them, how truthful are you? When you think about ethics, look at what branches out of ethics. Responsibility, fairness, right, wrong, honesty, principles, moral. All these, if you fail one of them as a nurse, then you are not a nurse. You are not a nurse, excuse me. As a matter of fact, whatever your flaws are, you need to start working on them. Because what goes around comes around. We have the American Nursing Association Code of Ethics. You see, it's so important that they had to put it under 9 provisions. All I'm talking about, they now section them into 9 provisions. So this piece of document is so central to our practice over there that if you breach any of them, they will take your license from you. They will take your license from you. You can't even practice nursing. So which means there are things that needed to happen that the CMD needs to help us with. Unfortunately, the CMD cannot even do it alone. He has a boss. We have Commissioner of Health. The Commissioner cannot even do this alone. We have the Minister of Health. You see how it keeps going up and up and up. If this chain, if there is interruption, if we don't work together, we are not going to be able to achieve what we want to achieve to change the attitudes surrounding our nursing care. That is why I'm so grateful that the CMD is here today. I'm so grateful because he doesn't need to be told this. He needed to hear it, firsthand, this information. Because we need him. We need him so badly to channel our cries up there. Lawlessness. In Africa, we are so lawless. That is why things are not working. Okay? That's why things are not working. We want to make a change. At the UBTH level, it's not going to work. You know why? If Madam X is the head nurse of his unit, and CMD cousin is admitted to his unit, and the staff nurse, the other staff nurse, does not do something right, and Madam X, who is the head of the unit, tells Sister Patience, who is an RN, try to, caution her. Because she has that influence with the CMD, she picks up the phone and tells the CMD, listen, this woman won't be the head of this place. You go come out. She doesn't have the power to discipline her junior nurses because of who no man. You see, this is why we need the cooperation of the CMD, not to interfere with the head nurse of B3. If you promoted her to be the head nurse of B3, that means you've already looked at her credentials that she can do what you want her to do. So therefore, you leave her alone for her to do what she's supposed to do. When problem is coming, you're going to deal with her. She has to answer to you. That's why you don't want to meddle with her, the way she executes, her information. As long as she stays within her boundaries, that's all that is important. So if you are given that space to work like that, then your subordinate nurse we have to sit up. Because if she doesn't, first, verbal warning, right? The second, written warning. And then the third one is sack, what you call sack. Fire the patient, the nurse. You see, it looks like in UBTH or in the government, once you get a job, this is really amazing. It looks like when you get a job, it is inscribed on stone. Everybody's looking forward to when they will retire in UBTH. Really? What makes you think you'll be retired in UBTH? It shouldn't be that way. You will only be retired in UBTH and get those, whatever they pay them, like the severance pay and all that, in the end, if you perform right. But people know that when they get that position, they will stay there and they will keep getting promoted, even when they don't merit it, because of Uloma. So why do you then expect us to produce for you quality nursing care? We won't, because she knows that she's a CMD cousin. So she can afford to do whatever she wants to do. She will not be fired. She's going to retire. And we pay her for all her blunders. And we say we want good quality care in UBTH. It's not going to work. It's not going to work. If we see this happen here, this child nurse is supposed to pick up the phone and look for his boss. Well, who is the CMD boss? You go and report that. Okay? And then they will summon CMD to whatever that department they talk about it. Warning, don't ever meddle with her job. But we don't do that here. She's afraid of her job. She wants to feed her family. So therefore she'll keep zip her mouth. That nurse is going to continue doing that. I gave an example of when I was a student nurse here. I was doing my rotation in the L&D. That's what happened that night. We were 2 student nurses and the staff. She wanted to sleep for hours. You know what she made us do, student nurses? She made us put pacifiers in the mouth of all these babies in that baby unit. We put it in there and we taped them down. All these kids were muted. Okay? And then, unfortunately for us, the matron who did around that night. Baby unit is so quiet like a graveyard. She was like, what is going on here? So, and then, of course, our nurses was on break. She was sleeping. You know, our head nurse was sleeping. This woman made around and found these babies. She was like, oh my God. So listen, that woman was not fired. She continued to practice in UBTH. Should that person remain here? I'm sure she'll be retired and she's being paid for doing that. Really? Why? Because she knows somebody who knows somebody and who knows somebody. As a matter of fact, if that happens in the advanced world, the student nurses, that will be the end. We will not be able to do nursing. Anywhere we go, we will not be able to do any nursing. So that woman will be fired. She's not only being fired. They will report her to the State Board of Nursing and her license will be taken from her. That means she can't practice nursing. Talk less of retire and then we are paying you for committing blunders. So we want to make changes. This is what we are facing. That is why I said this lecture is just a speck in the ocean. So it's so many provisions, because I don't want to really hold us up a lot. But provision number 2, primary commitment. Your patient is your primary commitment. Your patient. Okay? You shouldn't be kissing butts of your head nurse because you want to be the favorite. No, your patient. Okay? You give the CMD his due respect, not at the expense of your patient care. You got to stand up for your patient. You have to know your professional boundaries. Okay? We have the doctors. You know their role, and you know where yours start, and then you know where yours end. You are working in collaboration with internal and external teams to foster that patient care. You are not an island. Okay? You can't do this by yourself. So when you want to work efficiently as a nurse, you want to be able to collaborate with the doctors, the lab scientists, everybody. Remember, you are the eyes and the ears of these patients. So therefore, you must do that. If they order laboratory work for your patient, you need to, monitor it. You don't wait for the lab technician to take their time. It's so outrageous. When you ask the nurses, have they done my father's lab? You'd be like, they are coming. No, it can't be like that. Then by the time you come, they take their time. It's closing time, they go home. Now they will do it again tomorrow. Listen, if you are not your patient advocate, the lab that was supposed to be used as a measure to treat this patient is being delayed. Who is paying the bills? The patient. She was supposed to spend 6 days on admission. Now she's going to be spending 10 days because the lab scientist is dragging her feet and not showing up on time. So you, as the nurse who is the patient advocate, you need to police them. This is what we do. We need a start lab on bed 12. The doctors want the result now. You see, you are pushing. That is what nurses do. Nurses should be involved in research work. This is another area of flaws, okay? Because we are not researching, like we are saying now, like when Madam Provost said, oh, nursing is going down. All we need to do is sit back and say, okay, what areas is going down in nursing? All of them. Okay, let's split them up. Let's begin to, let each person doing research on this area. The outcome will be well communicated to the CMD. And then they will not draw out a plan on how to effect this change. If we take it like that, chunk by chunk, everybody will be transformed. That's the continual education part. You have to educate yourself. And not just going to school, but you want to come and effect changes. Talking about how you take care of your patient. This just happened. This just happened in less than 24 hours ago. Please, can you tell me what is the meaning of emergency?
Cases that require urgent care.
Do we have an emergency unit here?
Yes, ma'am, we do.
This happened less than 24 hours ago in UBTH. Somebody was having an emergency issues. She came in with chest pain. Chest pains. I don't know about you all here. When you hear that word chest pains, you should be thinking the patient is having a heart attack, irrespective of if it's a referred pain from elsewhere to your chest. You have a gas pain, you can present a chest pain. Until proven otherwise, as far as I'm concerned, the patient is having a heart attack. What does that do? It makes you move fast because you have a window to act. Okay? If it means you want to put in those thrombolytics on board, you have a window to act now, fast. We don't have a 911 services for the patient to be treated en route to the hospital. Now this family member is able to drive this patient to the hospital. She came here at your entrance. Mother is panicking about this child, a young adult, who is, quote unquote, having a chest pain. And she rushed to them and said, please, my daughter is having chest pain and I need a wheelchair to move the patient. Do you know how this nurse responded? She said, I'm using this wheelchair to take another patient out to her unit. Really? To me, the one you are taking out is stable. There's something called priority of care. She even went ahead and explained to this nurse, this is who I am in this UBTH. I work here. Listen, I told her, I said, it doesn't matter who you are. As far as I'm concerned, this is an emergency room. We need to treat this patient now. So what happens if that was real chest pain, heart attack issue? How will you feel if that patient dies in that car? You have a window to open. How many people have slumped in their own apartments? And it's a true heart attack. do no harm. Okay? Sin of omission and commission. That is her experience. Listen, it didn't even end there. These nurses were callous. Callous. She had to run and take her child, daughter, who was 20-something years old, into the car and drove that child to another private hospital. And she works here. She's one of you. She's one of you. How can we stop this? I mean, she's a reputable person here. I'm thinking, if they can do that to you, that means it's really bad. Last night, the person is right here within you all, sitting right here, right now. Emergency room, is that what we call emergency room? I thought emergency room, when you, since we don't have 911 services, you hear there's a car stop. There should be somebody designated who is sitting at that reception that is going to rush in there, get the patient in, and triage the patient quickly, because it's an emergency. Use your nursing judgment to assess if it is a true emergency. As far as I'm concerned, this chest pain was a true emergency. But this is the way our nurses behaved. What do we do? How do we solve this puzzle? We got to do something. That is why our CMD needed to be here today. We want good quality care. Listen, if you throw a stone into the marketplace, it might hit your own mother. So we cannot do it this way. This is not working. I'm not going to go through the provisions because of time, but because I want to rush into the scenarios that I want to describe. That is really important for me. So anyway, it was 9 provisions that had to do with the way we should treat patients under our care. The nursing process is central to our care. You see, the 3 C's, central core of nursing profession. Who is in the center? The patient, the family, and the community. That's why you're a nurse. You are not a nurse because of you. You are a nurse because of the person, the family, and the community. Scenario number 1. I wanted to go through these clinical scenarios so that we can tie it into what we want. In 1983, a baby was born at home under traditional birth attendant. The baby had severe jaundice, and the mother brought him to the hospital. So, when they got here in UBTH, she did not have the money to do the care. And the doctors and whoever took care of them said, you can be coming from home for phototherapy. She was ignorant. She thought that was the best care they could give to her. So she went home with the baby and started coming from home for just phototherapy. And this got complicated with connectors. And this child had developmental delay, did not walk until about 5 years old, and became mentally challenged, and then seizures as well. From jaundice, a curable disease, left this child maimed for his life. When he was 26 years old, he wandered away from home in 2010. And she still has a mother who is 79 years old now. The woman is still looking through these doors to her home, that someday my son will walk through that door and give him the hug. She can't move past it. It didn't matter that she has 5 children in diaspora. It didn't matter the love they are showering her with. She's waiting for that one child that went out there, didn't come back. The child that was seen by medical professionals and nurses. in UBTH? Do you see the ripple effect of your action on families? This is another problem we have, is money for hand, back na ground kind of treatment. That somebody cannot buy 1 or 2 units of blood. You just wait, look at them and let them die. My cousin died from that because we couldn't provide the blood on time. How will you justify your treatment for this child? Did that boy deserve to be missing like that? Will you be happy if that was your loved one? Will you be happy if this woman, 79 years old, is still grieving over her child? Do no harm. Do unto others what you want others to do to you. What if I tell you that boy is my brother and that woman is my mother? That was my experience in UBTH. And because of that child, we had to organize Love Your Neighbor Rescue Mission International. Because as far as I live, I will not allow another child to suffer what my brother suffered. I won't. I will do my best to make sure that people in similar situations, that Love Your Neighbor Rescue Mission International will rescue such a person. Scenario number 2. 77-year-old woman was admitted to surgical ward with a history of type 2 diabetes, high blood pressure, and diabetic ulcer. She was scheduled for skin grafts, and she spent 10 days in UBTH without surgical treatment. She was there, lingering on. The nurses told her, "Madam, if you have to have a treatment, you need to go see the CMD, the consultant in his office to give him some bribe." To give him some bribe. Consultant did not come out one day to see this woman. They were pretending they were controlling her sugar. She waited, no treatment. This woman had to pay for the hospital bills for 10 days that she did not utilize. She discharged herself and went to a private institution to get treated for skin grafts. In UBTH, is that all we are worth? That if you don't see if you don't see the consultant privately, you don't get treated, really? Or they make you discharge yourself to their private clinic to be treated. We want to change our nursing care. It's not going to work if that is what we are doing right now. It won't work. What if I tell you that that same woman is my mother? That was my mother's experience in UBTH, my institution of training. That was painful. It was so painful. Scenario number 3. This is 86-year-old man with no prior medical history. He collapsed in his home and came to UBTH and received a diagnosis of cerebrovascular accident that we call stroke. Initially, he was in bed, half naked, and his head of bed was flat, with shortness of breath, of course. They managed to start an IV heplock without infusion, and a few hours later, he was gasping for air. So they, slap on his face, simple face mask. Oh, my students are not here. I was going to ask the percentage of oxygen being delivered but with just simple face mask. Not even non-rebreather, simple face mask. And this patient is breathless. At that time, they now started IV infusion. The urinary output of this patient was so concentrated like coffee. Okay, let's see the patient. I need to see the picture first. Picture. So that is the man. He was a chief in his John Were of his community. Okay. Yeah, not the one with the mask, the one with the nasal cannula. We'll just see if it's not, we'll just stop. Okay, that's so. That is the same man. CVA. Look at his lips, dried. Okay, you know that he's really super dehydrated. Nasal cannula, CVA, laying flat in bed. Okay, half naked. Half naked. Look at his urine. Look at his urine output. The patient is hemlock. Hemlock, no IV fluid. No, I mean, just the lips alone should tell you your patient is even so dehydrated. To me, that is, you are doing harm. This treatment here is below standard for a teaching hospital. What happens to dignity? Protecting our patients' privacy, dignity. This is the same patient. Remember, he died within 24 hours of arrival. This is the same patient. Where are the nurses? What happened to head of bed, 90 degrees, semi-Fowler and Fowler position? Where are they? Where is it? We can't even do that for our patients. We're waiting for the doctors to say, put the head of bed up. That's it, right there, 2021. Right? 2021 is like yesterday to me. That's what we can do for somebody who is dying. It's not even a hospice case. CVA, do we have protocols for those? Because I'm hearing that people are collapsing in their homes and they are coming to you. Don't you have protocols to manage CVAs? If we don't, then we need to look into those. It's important. Look at that. Look at the urine, so concentrated. That, to me, they were killing this patient. Even if he had a chance to survive, we didn't do anything for this patient. But we still pay the hospital bills at the end of the day, though. What if I tell you that was my father? That was my dad. I don't have to know the CND before my father should receive a high-level care in this hospital. Nobody, as a matter of fact, any patient that hit that door, we should treat them the way you need to be treated. Please. Well, where is our nursing? Where is it? Where did we hide them? Where did we hide them? The tender, loving care that you swore to when you were graduating, you're going to give to your patient. Where is it? Where is it? You are the patient's eyes and ears. You are the one to communicate with the doctors. We need to do this. We need to do that. Let them call you over, Sabi. It doesn't matter. You are working hard for your patient because you don't need anybody to say thank you. When you go home, you are so satisfied that you took care of that patient. Even if the patient dies, it's okay because you did your best. As a matter of fact, when I get patients under my care, I am always saying, thank God they have me. Because there's a role I need to play in your life. That is why I'm your nurse. Nurses, what are we doing? That was a 79-year-old female who had surgery on his hips. And the sugars, she had diabetes. And the nurses were careless about sugar management, the blood sugar management, that they checked the blood sugar of that patient and they documented somewhere it was 157. So the woman was waiting for the next action. The nurse came and said, "Madam, you never eat?" Like that. The attitude. The way the nurses just look down on the patient and their families. Is this my imagination? Honestly, it does. This is why we need to start enforcing some rules here. Because If a patient family ever complains about a nurse, the nurse's care, your job is finished. You're over. Until we start enforcing that, we're not going to see any changes. But again, who knows, man? We make that phone call from the comfort of their bedroom. We will not be able to fire that nurse. That is the problem. Okay? So, the woman has said, I dey wait for my insulin. Oh, you dey take insulin? You be diabetic? Really? I thought you are the nurse. I thought you know everything about me. They come. She went back there and looked and came back and said, it's 157. I was just watching the whole story. 157. Okay. I want my insulin. No, because the doctor wrote it as needed. That was when the doctor stepped in and said, of course, it's 157, but I need to take my insulin before I eat. No, because the other day, another patient, they don't put I guess we call it sliding scale over there. That is sugar between here and here, you give that. Between here and here, you give that. No, somebody was like that the other day, had a coma. So with that now, they don't do it like that anymore. Okay. The next sugar check was 200 and something, 257. I'm sorry, that's my mother. At this time, I was not going to give it in because she had skin graft before. Remember the one she left UBTH to go do it in private hospital? This time around, I'm not going to let that happen. I said, listen, the patient is telling you what she does with her body. She's in control of her blood sugar. She knows what I said, listen, even if her sugar is 100, she will take that 70-30, 20 units, plus 5 units of regular, and plus she's taking metformin. So she will not go hypoglycemic on you. She knows her body. Even if she's going to go hypoglycemic, she so knows her body, she knows what to take with signs of hypoglycemia. Go tell doctor. The attitude. If I have the power to fire her right there, I was going to do it. The attitude. What are we talking about? Go ask doctor. Are we that callous now? Are we that callous now? Talking to our patient family like that? Is it because we don't have systems in place to put us in check? I don't understand. So, do we honestly want to change our practice in UBTH? Sir, do we want to transform our nurses? It's going to start at the individual level. That, you go back to the basis of what Mrs. Agawa taught you. We need to renew our consciences on how we deal with individual patients. If we don't do that, it's not going to work either. It is a mind and a practice that is malleable that the CMD can help. Because if you are not ready to change, it doesn't even matter the policies and procedures that are going to be put in place that will work. Because he will not be with you at the patient bedside. And our population out there, many of them are illiterate. So they are afraid of nurses. Oga, madam. Some of them are so afraid of us that they feel like they have to bring us head of a plantain to bribe you so that you can do what you are trained to do. Right? So if we want to make the changes that Madam Provost is craving for, we need to do something called transformative lifetime journey. It's a pyramid. At the departmental level or institution level here, the CMD is on top there. Like I told you before, he is answerable to somebody at the local government, state, and federal. So we have the policies that need to be written. We have our nursing board. They will work in collaboration with these policies, with our institution, to be able to enforce what we want to change. Over there, there's something we call mandatory annual competencies. That is, these are trainings I think I told some of the students they need to do this. Mandatory annual competencies. Your continuous practice as a nurse in UBTH is going to be based on that. Every year, he's going to draft whatever, in any way you think our nurses, they have attitude, they are not doing this and that. Everything is condensed to these classes that will be about 8 hours. You go through it every year if you want to maintain your job. They give you a deadline. If you don't do it, you want to go clock in the next day, your number will not be working to clock in. Anyway, you will do it because that is the rule. So if we work, it's so difficult to work in a place that is lawless. So this is how we are going to keep these people in check. So annual competencies. After doing that, if you violate any of these policies, then verbal warning, written warning, and then you are fired or sacked. We practice human caring. We're not dealing with robots. If you had that at the back of your mind, that you're dealing with a human being and a robot, then now you're ready to be a nurse. We listen to our patients. If we want to make a change, you are here, you clocked in because of this patient. Where are you hurrying to? I love the way they practice nursing in the UK. Oh my goodness, in their eyes. There is a time allotted to when you actually sit with your patient. You talk to your patient. You remember the trust we're talking about? This is how you earn their. You are ready to, whatever you want to talk about, I'm ready to listen. Some of them will be telling you something about, my husband, this, my husband, that, oh, my senior son is doing this and that. You are helping them solve their problem. You know why? We have to treat the patient as a whole. If your patient's social life is messed up, all your treatment may not work. So it's a whole entity, body, soul, and spirit. And he's ready to tell you about his emotional problems. You better be ready to sit down and listen. We'll listen. We'll listen when the patient tells you, Madam, I don't take Tylenol. They say I shouldn't take Tylenol. Doctor, order her now. I better take. Really? No. She knows her body. She said she doesn't take Tylenol. You don't know if there's a liver issue along the way. Right? We don't want you to give them Tylenol to cause hepatic coma. You listen. I know my body more than you know it. You listen to your patient. Don't think it's over-sabi. It's not over-sabi. They know their bodies. Okay? So the patient that you have right in front of you, they have value system. They have spiritual part of them. I don't care what kind of religion they practice. They are there you are there to support whatever practices that they have in their own personal lives. You are working so hard to earn your patient's trust. If you want to make changes, you want a patient to be so relaxed when they have you as their nurse. And they'll begin to tell you things in confidence. Some of them, they will so trust you with even the money they have, their estate. You know how many of our people out there that families, they will fortune to them because they trusted you. You listen. They just wanted a pair of ears to listen. So, yeah, some people don't have anything to, they don't even know what they want to do with their money. Are we ready? I know that many people are going to school these days. Almost everybody is pursuing one degree or the other. But are we ready to pursue? It's not enough to pursue that degree. Are we ready to apply it? Application is important. As you get that degree, let the CMD know that the 4 years or 2 years he gave to you to go seek that degree is going to be beneficial to the institution. Not for you because of promotion, not necessarily. Okay? It is, you want to be so transformed and effect some changes in your department. That is why we send you to school and pay all that money for you for free, not for your promotion. can we engage in continuous quality improvements? When we go wrong, it's okay for you to report her. The problem with the reporting system in Africa is that we always think if you report the situation you witnessed, she's going to get fired. This is where the management has to come in. It shouldn't be like that. She doesn't have to be fired. Because if you fire her, we are not going to learn from similar situation. There's something called verbal warning. Okay? You take that situation that they reported to you. You now develop some policies around that. It becomes part of our UBTH documentation and part of our annual competencies, if you want to effect a change. That will encourage more people to open up their mouths when something is going wrong. Over time, you see us being transformed. But our own is just to fire you. Can we be cognizant of the cost of care? Since we know that this part of the world is money for hand, back na ground kind of care, can we be very, very cautious of how we delay our patients on the unit? Instead of 5 days admission, it's becoming 2 weeks because somebody have not gone to see the consultant. Is there any way we can reverse that process for somebody to, intervene? Can we partner with other departments too? We need to be able to work with the other department if we want to give quality care to our patients. So this is going to be the outcome of UBTH overall values. If we align that with these, integrity, so that it doesn't matter what part of the state of this country that I'm in, when we mention UBTH, we should be known for something. Okay? Oh, their nurses are so courteous. Oh, they are very loving. Oh, my mother went there. It was a very beautiful experience. I will want to go there again. This is how we get references to come and visit this institution again. Because of your care, it spreads. Your good news will spread everywhere. So these integrity, compassion, excellence, innovation, stewardship, teamwork and collaboration, respect and diversity. If we can uphold this, then we are heading somewhere. So, I just want to thank you all for your audience. Thank you, Mr. CMD, for coming today. Sima, thank you so much. And Madam Gawa, thank you.
Thank you very much.
Thank you so much. Oh, thank you, sir. Thank you, sir. Thank you. Oh, mommy. I'm proud of you, my daughter. Thank you, mommy.
In fact, after preparing the letter, I said, how can this or that part be removed? He said, you wouldn't have just informed me. It's like God wants me to empty my mind so that I can feel good again. I said, okay. I didn't know that she had some of this experience. I was aware of some. Are we ready to change? Our dynamic CMD have been looking for this opportunity. We tried at the beginning of this year. It didn't work out. The person that was supposed to come to give us the lecture got to Lagos because of insecurity. He didn't get to Benin. He was asked not to come to Benin, so he didn't come. Then we had another opportunity last week. Then she called me to say, no, I won't be around. I say, which kind of wahala be this? And not up to a week, my friend just called me. Yes, I'm in town. I say, okay. This is another opportunity. And when I was approaching her, I was just begging her passionately, please don't say, I can do anything for you. And here she is today. Please. Let this lecture be a turning point in our lives and in the life of our institution. MABEL, thank you very much. To our dynamic CMD, sir, thank you. But for him, I wouldn't have even reasoned this way, because he kept saying it, that if they hear from those from diaspora, from a different person entirely, they will listen. And we have all listened. Are we ready to apply it? Are we ready? We are not perfect, but we can strive towards perfection. And if we do that, it will go a long way. My immediate boss, thank you very much. Even while we were making this preparation, our CMD was not around, but he was very supportive. He kept saying, go on, go on. And our mama in the house, I kept reporting to her, I said, you self, you are two officials, just go ahead. Thank you very much, ma'am, for the support. And to everyone here present, I want to say a very big thank you. Thank you, thank you. And our mama that taught us how to carry the bedpan with dignity. Thank you very much, ma'am. You can see that your effort is not wasted. We are carrying on the legacy and we will continue to do so. Thank you very much, ma'am. 2017 intake. Yes. Thank you very much, ma'am.